Good morning. Actually, it's still not morning anymore, so good afternoon. Thanks for sticking around. I really appreciate it. I think we have some pretty interesting data that we've been collecting at Mount St. Mary's for the past 2 years. And what we're looking at is the change in lower extremity mobility after a thoracic manipulation. So over the past couple of years, probably the last 4 or 5 years, there's actually been a large increase in interest in how the body works, how various portions of the body can relate. This concept has been termed regional interdependence. Most of the research involving regional interdependence has dealt solely or primarily with the upper quarter. You see studies with Cleveland, Fernandez, De Las Pinas, and Puntadura recently looking at how thoracic manipulation can impact cervical function. In addition, there's been some studies recently that looked at how thoracic manipulation can also impact shoulder function. But to date, nothing has really looked at how thoracic manipulation can actually impact lower extremity mobility. So we're interested to see, is there an effect that occurs not only in the upper quarter, but can thoracic manipulation can impact things that are going down in the lower quarter? So this is the first study that we know of that looks at that relationship. So our research purpose, therefore, is to determine whether there's a relationship that exists between lower extremity mobility and passive straight leg raise as measured after a treatment of mid-thoracic manipulation. So we're looking at a couple things. We're looking at the relationship between passive straight leg raise and manipulation. Our research hypothesis was therefore there will be a significant difference in straight leg raise measurements following manipulation of the mid-thoracic spine. And we looked at it under 2 conditions: immediately after, and we also looked at it 1 week after. Our subject pool was 41 subjects who were randomly assigned in a double-blinded study that we took symptomatic and asymptomatic patients. And it was primarily a convenient sample of students from Mount St. Mary's College. And that was collected over a 2-year time frame. So in terms of our research design, it was a randomized controlled trial. We had repeated measures, pre-intervention, post-intervention, and a 1-week follow-up. Our treatment groups, we had 2 treatment groups. We had an experimental group, which got manipulation of the mid-thoracic spine, and we had a control group, which got a sham manipulation. And in this case, sham manipulation was everything was set up the same. They had a flat hand instead of a pistol grip underneath, and there was no thrust delivered. So all the positioning was the same. So 2 groups, manipulation and sham. In terms of the methods, what we first did was we took a visual analog scale, so VAS, and then we had the patient prone and we did central PAs to the mid-thoracic spine to assess hypermobility, and we identified a segment or segments that were hypomobile or tender. And next we immobilized the patient into extension of the knee and dorsiflexion of the ankle, and we used this sophisticated device, not as sophisticated as the pressure mat they used, but a piece of 2x4, and that braced the person into extension. And we strapped them down into extension. And we also strapped the contralateral leg into extension to prevent pelvic rotation. So we used a gate belt that was locked into the plank. The tester was then lifted the leg up until initial onset of symptoms. And for the symptoms, what we did was we clarified it as tightness, tension, nerve symptoms, anything that the patient experienced in the leg, that was our stopping point. Okay, that's where we took our measurement. So then what we did is we placed an inclinometer on the tibial tuberosity and measured the angle. And then the leg was returned to a resting position. And a VAS was re-administered. At this point, we did the manipulation in supine, and then we reassessed the straight leg raise and re-administered the VAS. And then we asked them to come back a week later, and we retested VAS and straight leg raise. Oh, too loud, sorry. And this is what we did. So we lift the right leg up. They gave us information on when they felt a pull, and then someone else would come in and measure it. We then got them ready for the manipulation. Put our hand underneath. Flex them up to the level. 1, 2, better not 2. Got them into the manipulation. And then remeasured. So fairly simple design. Straight leg measure, intervention, remeasure. Our demographic information, we had 41 subjects, and they were fairly even between the two groups, the experimental and control. Ages were fairly similar. The one thing that was significantly different was the male-female ratio. In terms of data analysis, what we ended up doing was a one-way ANOVA, looking at percent change in straight leg raise. And we also looked at mean change in straight leg raise. So the results of our ANOVA, immediately after the manipulation, we saw a significant change in straight leg raise. Okay, so there's an immediate change in straight leg raise right after. At the 1 week follow-up, there was no significant change. So it returned to the baseline values. So no significant change. In terms of the mean change in straight leg raise, immediately post-intervention, we had a 6.4 degree change. And at 1 week, we had a 4.5 degree change. And what's the importance of this? Well, MDC for straight leg raise is 2.7 to 3.4. So in both cases, we had a minimal detectable change. It's just remember that the immediate post-intervention was significant, and the post 1 week was not significant. Looking at this graphically, you can see that in the manipulation group on the left, that there was a significant change, both at 1 week and immediately after. And in comparison with the sham, there's not really any change. So what were some of our study limitations? Well, there was a convenient sample. There was that gender differential. There was a limited number of subjects, so there were 41 subjects. Unequal number of groupings, there's 22 in one and 19 in the other. And the fact that we accrued data over a couple of years, that was one of the limitations also. So what's the meaning of this? What's the discussion? Well, a relationship may exist between the thoracic spine and the lower extremity, okay? And manipulation may affect both of those. But the main discussion point also is that change we saw immediately is lost by 1 week. Physiologically, the mechanisms of this is still quite unclear. If you look at it purely from a pathoanatomical standpoint, you can say that maybe in thoracic manipulation, what we did was change neuroadhesions or scar tissue that formed within the thoracic spine, and therefore we got changes in neurodynamics. But if really that was the true reason that we saw these changes, we would expect to see changes at the 1 week follow-up also. So that leads us to think that potentially there might be changes in neurophysiology or cognitive processing that might be accounting for some of these changes.